Well, whenever you use radiation to treat cancer patients, one of the first questions you have to ask is, what are you going to radiate? And in some circumstances, we only radiate the primary tumor site. So, for example, if you're treating somebody with head and neck cancer, if they have a tongue cancer, do you just radiate the tongue or do you radiate the neck nodes? In prostate cancer, one of the questions that have been out there for many years is, what do we radiate? We can, based on pretreatment features such as PSA, Gleason score, and stage, we can estimate which patients are at risk for having recurrences in their lymphatics. And with modern imaging, with PSMA PET scans, we're able to see that it is a common pattern of recurrence is in the lymph nodes. And so the question is, can we identify which patients are likely to benefit from having their pelvic lymph nodes radiated? And if we can, and we do, that is, we radiate the lymph nodes, will that treatment of the lymph nodes result in survival, increased survival from prostate cancer? And so this study really is designed to take the patients that are at risk, but a relatively low risk or a modest risk, around 15%, which means 85% don't have it, all the way up to patients that have a higher risk of lymph node involvement, to try to figure out whether there's a specific category of patients that might benefit. And so we randomized patients who were receiving hormone therapy and radiation, who are categorized as having unfavorable intermediate risk or favorable high risk. We didn't want to take the very highest risk patients who had obvious lymph node involvement or were extremely high risk, because we were concerned that it may not be ethical. All of our old studies, we routinely treated the pelvic lymph nodes in the old studies going back 20 years, 30 years, like that. So we wanted to see if we moved it earlier into categories of patients that were at risk, but not so high risk that we felt uncomfortable that they could benefit from having their lymph nodes treated. So as the title of the abstract suggests, these are the early results. And so I would say that in just to be brief, I think we need longer follow-up to answer the questions. But you haven't read the abstract, but it suggests that there's a difference in the risk of having biochemical failure, but biochemical failure is not a surrogate for death from prostate cancer. So the bottom line is that we still don't know because the follow-up is relatively short. The median follow-up is 7.3 years. And most of the people that die of prostate cancer die after 10 years. So we think that we are encouraged by the fact that with longer follow-up, we should be able to answer the question. But at this point, we don't have an answer. Well, it's just randomized patients to either have only their prostate radiated or to have their prostate and their lymph nodes radiated. And then, again, the primary endpoint was survival, overall survival. And the importance, most trials that are done involve drugs, and drug companies pay for it. So I think one of the great challenges to doing a study like this is that this is simply a radiation question. It's not a drug question. Most drug question studies are paid for by drug companies. So this had to be paid for by the National Institute of Health or the National Cancer Institute in the US, because this is simply a radiation question. Do we radiate only the prostate? And we will have biomarkers. It may be that if somebody put a gun in my head and said, you got to tell me what's going to happen downstream, I would say that probably using biomarkers we will be able to identify subsets of patients who might benefit using biomarkers, but that our clinical estimates of which patients are at risk for lymph node involvement are too crude and insensitive to be able to select out patients well. That's why it's a pretty large study. It's the largest study ever done in localized prostate cancer, with the primary endpoint being survival. And we felt like we needed these many people because there's a lot of drop off. You have 500 patients have died, in the first 10 years, most of the vast majority of which had nothing to do with prostate cancer. So you can see that if you're going to need enough patients between 10 and 20 years to be able to answer the question statistically, you have to start off with a high number of patients in order to get the question answered. A small study could not do it because there are other competing causes of death other than prostate cancer. There's no, or at 10 years, there's no survival difference. Many people, part of the reason I decided to do this, you haven't seen the abstract, the presentation is not until Sunday, is that there are a lot of people that are going to walk away from the results and conclude that the results are negative, that it proved that you don't need to do it. And I would argue that no, the results are not negative, that longer follow-up is needed. So the bottom line is stay tuned. In the next 3 to 5 years, I suspect that we will have sufficient statistical power to tell us whether or not radiating the lymph nodes prophylactically will actually result in a survival difference.